Thank you guys. And Kelly, if at any point there is a question, let me know. Sometimes it's not popping up on my screen, so just, wave your hand. I want it to be as much of a dialogue as it can be. So I always love at every opportunity to point out whatever your role is as part of the healthcare team, whether you're inpatient or outpatient, whether you are a specialist or primary care, whether you are clinical or non-clinical, whether you work in an operating room or an emergency room, you have many opportunities to positively influence a breastfeeding woman's feeding experience. Many of my colleagues in medicine often don't even realize those opportunities, let alone realize the consequences of those missed opportunities. If you ask many of my colleagues in medicine what advocating for a breastfeeding woman looks like, they will say things like, always give them the recommendations regarding breastfeeding. Maybe doing some, hands-on lactation support, which very small amount of my colleagues feel comfortable doing that. Or thirdly, referring a patient to go see a lactation consultant, which again, many of my colleagues might not even know how or when or even why a patient should be referred to a lactation consultant. But after hearing many of my, rants or soapboxes, as I call them, my colleagues here at my institution, and hopefully you all as well by the end of this talk, will understand that in addition to providing those things I discussed about, hands-on care, there are so many opportunities that all of us as part of the healthcare support system can positively influence a breastfeeding woman's feeding experience. So for the next little bit, we're going to go through some of this statistics around breastfeeding data, whether that's across the country or looking at our state individually. We're also going to identify some of the potential barriers to achieving success in breastfeeding. And as we explore those, we will often understand why for some of our patients, those barriers will even feel like giant mountains, but for some of our other patients, that the absence of those barriers will feel like a rocket ship propelling them to achieving their breastfeeding successes. In addition, we're going to, really explore all of the vast misinformation that a ton of our patients are unfortunately hearing regarding things like breastfeeding safety with anesthesia, radiology, and medications. So, like a majority of pediatricians, I do not have any financial disclosures to report, but it is important to know for the sake of this talk that I did exclusively breastfeed both of my children. My first one, I weaned him shortly after he turned 3 years old. My second one, I'm still breastfeeding him, and he turns 2 in September. I understand that my success in breastfeeding is attributable to so many different things, ranging from the color of my skin, my income, the fact I had paid maternity leave, a supportive family, my education, a supportive workplace, and so much more. And I understand that for a majority of the patients I serve in West Virginia, those privileges are absent. And because of that experience, it has really shifted the way that I have conversations regarding breastfeeding education and breastfeeding in general with patients. So we are all aware of the recommendations from both the American Academy of Pediatrics and the World Health Organization of having exclusive breastfeeding through a period of 6 months and continued breastfeeding life beyond the second year of life, as long as family decides. But unfortunately, like a lot of areas in medicine, recommendations don't always translate to the actual reality. The data here highlights information from the CDC. It's called the Breastfeeding Report Card. And this is from our most recent data of infants born in 2021. And going through this, it looks at a couple different touch points. Starting out, it looks at the percentage of infants who ever were breastfed. Then it goes down to, and that's around 84%. Then it looks at infants receiving any breast milk through a period of 6 months, which is around 60%, 12 months, which is around 40%. And then exclusive breastfeeding data, that number goes down even more through a period of 3 months, around 46%, and 6 months, around 27%. But the information that's most important to me personally is that according to the National Institute for Children's Health Quality, 60% of families don't meet their specific goals for their breastfeeding, whether that's exclusive, inclusive, they aren't meeting their goals. So I want to take a closer look at West Virginia's data. And this is from that breastfeeding report card. And the table to the right breaks down West Virginia's data and compares to our country as a whole, and then 2 of our bordering states in Ohio and Pennsylvania. And as you can see, sadly, West Virginia, there's quite a bit of a gap. In 2022, the Journal of Perinatology took an in-depth look at this data and really looked at what hurdles were in place and what measures needed to occur to achieve what's called the Healthy People 2030 indicators, which I'm going to talk about that next. And unfortunately, West Virginia is at the bottom for having the lowest 6-month exclusive breastfeeding rate, as well as the lowest for having 12 months of any breastfeeding. So that's unfortunate. As someone who did exclusively breastfeed, it makes me sad when I see that my experience was only shared with about 14% of other West Virginia women. Interestingly, this study in the Journal of Perinatology also looked at the prevalence of infants who were ever breastfed or breastfed for at least 6 months were higher in states that had enacted one or more legislative policies geared to increasing breastfeeding rates. Also in the article, it looked at how researchers examined the association between how long of a maternity leave a mom took and what their breastfeeding initiation and continuation rates at 1, 2, and 3 months in a cohort of around 12,000 postpartum women. The data showed about 2/3 of women reported taking less than a period of 3 months, and having a period less than that time, whether it was paid or unpaid, was associated with having a lower prevalence of continued breastfeeding at either the 2 or 3 month postpartum. This isn't really surprising, and it supports the expert opinion that having regional laws and legislative policies in place positively influence your breastfeeding rates. So we've talked about where as a state right now, if we take a shift back, how far have we come as a country? So in 1970s, our country saw our absolute lowest breastfeeding rates. We had the development of the Women, Infants, and Children program, and into the 70s, breastfeeding research was just starting. Moving into the 80s, breastfeeding research clearly documented the information we all know about how breastfed infants have decreased incidence of ear infections, respiratory illnesses, and GI illnesses. And then moving into the 90s, in 1991, UNICEF and the World Health Organization launched what is called our Baby Friendly Hospital Initiative. And as you can see from that period on, you can see a steady climb. Our red stars indicate where our most recent breastfeeding report card data is. So continue to have a climb, but a bit of a plateau over the last 5 or so years. So now looking ahead, where do we go from here? So every 10 years, the CDC comes out with what's called the Healthy People Objectives, and there are some specific goals regarding to breastfeeding. So when looking at the proportion of infants who are breastfed at any capacity of 1 year, the goal was to go from a baseline of around 36% to a target of 54%. And again, West Virginia, we're at around 19%. When we look at exclusive breastfeeding data, the goal by 2030 is to go from our baseline as a country of 25% to a goal of 42%. And in West Virginia, we're at around 14%. These maps were taken from that Journal of Perinatology article, and it really highlights what measures and how far we have to go as a state. You can see that, how we really stand out, how far we have to go to achieve those Healthy People 2030 breastfeeding objectives. So according to the CDC, how long a mom breastfeeds her baby is influenced by a ton of different factors. I highlighted the ones in light blue because I feel like these are ones that, as members of the healthcare team, as people who are passionate about breastfeeding, we have the opportunity that we can help. So these are issues with latching and lactation, concerns about, is my baby gaining enough weight? Mom's concern about her medications, are they safe? Unsupportive hospital practices, whether that's in the newborn period or throughout her breastfeeding journey, unsupportive work policies or parental leave. We may not have direct control of that, but we do have the opportunity that we can advocate for our coworkers. We can take the initiative and say, hey, I'll cover you while you go take your pump break. And then finally, cultural norm and lack of support. So in 2011, the Surgeon General identified, had a call to action, identified barriers to breastfeeding success. And although it was 14 years ago, really a lot of the barriers stay the same. We're going to go through each of those. And while we're going through that, I want you to think about some of the patients you've encountered, or maybe your own feeding experience or family members. And I want you to think about how some of these barriers potentially change your breastfeeding journey, or maybe the absence of these barriers really helped you. And I want you to think about maybe some experiences with these barriers where, in hindsight, you may have received misinformation, and that may have stopped your journey earlier than expected. So the first barrier we're going to look at is barriers related to health services. And this is a picture of my co-workers' adorable twins. And so what this barrier is, which is the one that I'm really going to spend the most time on, is we're going to discuss safe medications in postpartum depression, anxiety, safe medications in chronic illnesses, antibiotics, and more, how things are safe with anesthesia, breastfeeding, radiology, all of those things. And then finally, why you should rarely, if at all, say pump and dump. I always have students, I have PA students, medical students, and whether they go into pathology, radiology, one takeaway they all know is that I will haunt them on their little shoulder if at any point I hear that they have told a mom to pump and dump. So there's a lot on this slide, but this is the most important slide. If you're able to, screenshot it, I have the links below. Put this in your phone, print it off, and put it at your workstation. Anytime, have this, because this is what we're really going through in the next little bit that has such high yield information. So first off, we're going to look at anesthesia and breastfeeding. So this infographic to the right was taken from the anesthesia organization. So as you can see here, from that below is the screenshot of the article. So I'm going to include some patients I've encountered with this barrier, and kind of discuss how I navigated that. So I had a 24-year-old woman who was 6 months postpartum, who was breastfeeding, who needed her tonsils and adenoid out. Her ENT told her, unfortunately, she had to stop breastfeeding. She reached out to our lactation office. They reached out to me. We connected the dots. We provided the anesthesiologist with this information, and she was able to have her procedure without any issues. So when we talk about anesthesia and breastfeeding, the thing that we really want to talk about is what's called the relative infant dose. And what that means is it provides an indication of how much the baby is being exposed to of the actual substance. It takes into consideration things like mom's weight, baby's weight, how concentrated the drug is in breast milk, and indicates a percentage of the drug in the baby relative to the mom. And as a rule of thumb, levels less than 10% are generally considered safe. And when you look at most anesthetic drugs, with the exception of morphine, they're all significantly less than 10. So this policy statement's another one I would have printed out or have easily accessible. It was updated in 2024. It's by the American Society of Anesthesiologists, and it's excellent. It breaks down each med class. It's very valuable. And they talk about how opioids and their metabolites may transfer in slightly higher levels to breast milk, but it's important that anesthesiologists add other classes of analgesics when appropriate in order to try and give the smallest dose possible. So again, as you can see, all this information is taken directly from that policy statement. The only real hard stop is that tramadol. Codeine has that iffy information depending on mom's history with that, but all of other these proceed on. Here we have another patient. This is just one, but I would say this is the most common thing I hear. A 31-year-old female, 9 months postpartum, needing dental work. I can't tell you how many dentists in the Middle Ohio Valley I have sent sent this information to. So many women are told after having a cavity filled, which would be topical lidocaine, Novocaine, whatever, that they have to pump and dump. As you can see, local anesthetics, it's 0.1%. When you look at other medications, so this whole entire list, as you can see, tiny, tiny amounts. This direct quote is from that policy statement, and I love it. It says, patient should resume breastfeeding as soon as desired after surgery because anesthetic drugs appear in such low levels in breast milk. It's not recommended that a patient pump and dump, but rather they should sleep and keep. I love that. So it's a great one. We get a lot of calls at it, and it's so great. I'm really trying to shift from problem solving when it happens to giving the providers or giving the patients this information themselves so that they can be their own advocate. So I'm sure you all have experienced firsthand how heightened some of these experiences can be. People get very emotional when talking about this, and many of you may not have experienced talking to another healthcare provider. The first time I called a surgeon or a dentist and said, "Hey, I think you said the wrong thing," it was pretty stressful. So one method, communication method I like to talk about is the CVS method, which stands for clarify, which means tell me more, validate, your feelings are valid and common, and solutions. Let's find a different way to solve this. So here we have a patient that was called to assist, a 26-year-old female, 5 months postpartum, who just had a hernia repair. They're in PACU. Mom's awake. She brought her pump with her. Grandma, so mother-in-law, was saying, "Hey, you should just, dump the milk for a couple of days. It's not worth the risk." How many times have we heard this? So we go down and I say to the mother-in-law for clarify, tell me what you've heard about the risk of baby getting anesthesia, getting breast milk after anesthesia. They answer, and then we move on to our validate. I understand you want to make sure the baby is safe, and I appreciate your concern. There is so much misinformation out there. It's hard kind of to decide what is right and what is wrong. So here's a picture, which I refer to. I'm so proud of this. This is hot off the press in our institution. It's a labor of love. This is could be a badge buddy. We're going to be incorporating it in some of patient rooms. Ideally, if you're in PACU, OR, ER, anywhere that these medications are given, you have readily access to this, so that I can bring this up. So I didn't have this at that time, but I always keep a picture of that anesthesiology infographic on my phone, and I say, here's a picture with all the data from the people who make all the rules in anesthesia, and all the medicines your daughter-in-law got are in the green. A general rule of thumb is that if a mom is awake enough and stable enough to feed the baby, feed the baby. And I always love to point out the fact that moms sometimes get general anesthesia when they have a C-section. They wake up and they feed their baby. So we went through anesthesia and safety. And again, so many questions can be addressed by just that one single infographic and referencing that anesthesiology policy statement. Next, we're going to go into radiology. So this table was taken from the ABM protocol, another wonderful, very detailed policy. And as you can see, looks out the imaging type, and then is there any breastfeeding interruption? And as you can see, for these most common ones, CT, MRI, X-ray, mammogram, no interruption. Feed the baby, pump the milk without any delay. The ones that I get the most calls about are things with contrast media, whether that's CT or MRI. Another policy statement to keep, because a lot of radiologists, they have so much information they have to keep up with, they might not even be aware. I found that of this updated policy statement. The American College of Radiology updated their policy on contrast with breastfeeding moms in 2024. And they broke it down even into the amounts. So in moms receiving IV or IA contrast, the baby's receiving less than 0.01% of the contrast medium and absorbed into the infant's gut. When you look at MRIs with gadolinium base, it's even less, 0.0004% of that contrast is what the baby's receiving. So based off this information and based off the recommendations of the American College of Radiology, there is no data to suggest that there should be any delay in breastfeeding and any discarding of the milk. The next area. So I had a 27-year-old woman, 5 months postpartum. Her PCP ordered a workup for having a thyroid order. This is probably the most common caveat for pausing. So when looking at the different radionuclides, so the recommendations with regards to breastfeeding after receiving I-123 vary. Some say, none, others recommended more. But when talking with our radiologist, the most common radionuclide used is this technetium-99 protectate. It's quite a mouthful. And the breastfeeding recommendations and it depend on what dose is administered. It can be as small as 4 hours, and it can be up to periods of 24 hours. And during that period of time, the milk can be expressed, stored, put in the refrigerator, and given to the infant after a period of the physical half-lives, or about 60 hours have elapsed. So as you can see here with that, and if a person's receiving this I-131, which is really not that common at all, it is requiring complete cessation of breastfeeding. The next case, I have a 36-year-old female, was called from the ED 2 weeks postpartum. She was downstairs for having a rule out PE or pulmonary embolus, and she has a contrast allergy. So we all know the recommended modality of diagnosing a PE is typically a CT angiogram, but in patients who have kidney issues or have contrast allergy, VQ scans are the next step. And depending on what, again, radionuclide is used, depends on how long of a period. So kind of at most, it would be the milk can be expressed, stored and refrigerated, not dumped, but given back to the infant after a period of 10 physical half-lives or 60 hours have elapsed. So again, we're pumping, we're storing, but we are not dumping. So with that. The next one that is near and dear to my heart, I experienced a case similar to this personally. And being your own patient advocate can be challenging. So we have a 38-year-old female, 18 months postpartum, BRCA positive. I want to shout this from the rooftop. Diagnostic breast imaging during lactation is the same as that for non-lactating women. There is no contraindication to receiving a mammogram during lactation. It is important, though, that moms are given the information that you need to either nurse or pump to empty right before your mammogram in order to improve the quality of the image. And also let them know, don't be surprised if you need an ultrasound to be used in conjunction with that mammogram. So quickly going through some of these other things which you may encounter. Again, all of this is in that ABM protocol. Renal imaging, no interruption. Nuclear medicine, as long as the dose is less than an amount of 100 mREMs, no interruption. PET scan, interestingly, if a patient's receiving a PET scan, the FDG is not excreted into milk, but it is concentrated in the breast tissue itself. So mom and baby have to be separated for a period of time, typically 12 hours, but the milk itself is safe and can be given to baby. Bone scan, very very little is excreted, no interruption. Cardiac imaging is depending on if you have a MUGA scan with either in vitro or in vivo labeling. Again, not a cardiologist, but I have met with our cardiology staff here. Our imaging staff have pictures and have links to all of these recommendations and can address that if it comes up. Next, we have a 26-year-old female, 5 months, PCP ordered an MRI with contrast for a headache workup. So this is one that sometimes can be tricky. So you say, I know there's a lot of information, a lot of misinformation out there, but I want you to be aware that it's perfectly safe that after you have your MRI, you can feed your baby without delay. Patient responded, my PCP actually told me I'd have to, unfortunately, pump and dump for the next 24 hours. Now we go to our clarify. Did he happen to give you any printed information or explain why? No, it's just what he said. Validate. I understand you want to make sure your baby is safe, and I know you trust your PCP. It is so hard for our providers to keep up with all the current information. Medicines change all the time, guidelines change. I'm sure your PCP had the best intentions when he gave you that advice. And that's what is important for us to know. When misinformation is given, it's not given out of malice. Usually it's just out of fear. A lot of different specialties really have a gap in their breastfeeding knowledge. And so sometimes their safety net is to just say dump. So in this instance, we said, here's an official picture with the information from the organization that decides all the rules and guidelines and what's safe in radiology. And as you can see, MRI is safe. I want to, we'll make sure that your PCP gets this information, and I'll give you this physical copy. So, we tackled our anesthesiology graphic. Our next area is radiology. So our goal, hopefully by the end of August, is that we will have a hospital-friendly infographic that will be in our radiology suites, and we'll have our providers in the community will have access to that as well. So we address anesthesia, we address radiology. We're going to go through meds now. So is this medication safe? There's a couple different ways you can look. I love Infant Risk. I love the Infant Risk app on my phone. It does cost a couple dollars, but it's a great app. I encourage moms or families to get the Mommy Meds app as well. The call center is available. The compatibility websites, we have LactMed. We used to have Trash the Pump and Dump. I loved it. It's no longer available, but LactMed is a great resource for people to, check out and see if the medication's safe. So if you're a prescriber, it's important that you're engaging what's called shared decision-making. So that's this process of giving as much information to the patient as possible so that the patient with the practitioner decides together in choosing the medication. Most medicines in general don't absolutely require pumping and dumping. There are certain known theoretical risks when counseling lactating patients. It's hard sometimes to create studies with medications with lactation, but sometimes we can look at things like what is the molecular weight or the half-life of the drug, and have these discussions with patients. It's important that our patients get all the known and theoretical risks regarding the medication, including will it hurt their supply. The benefit of the medication to help the parent may outweigh the potential risk, and a lot of things like in our anxiety, depression, and other medications in that class. But if the lactating parent and clinician decide together that our risk outweigh the benefit, there are other options to just completely stopping that we can have a discussion about. So if you aren't familiar with this are the different kind of levels based off the evidence available with medications. L1, tons of data on the medication, safe. L2, not as much data, probably safe. L3, I underline it to kind of highlight that, this was yellow, but green, but still kind of yellow, that there is limited data, presumed compatible. L4 is our limited data, possibly hazardous. So here we had, I was one of our first, after I gave a grand rounds talk here to all of the adult medicine providers. This is one of the first patients I had that I had an epic chat from an electronic health record chat from a adult hospitalist asking questions, asking this patient, a 29-year-old female, 8 months postpartum admitted with urosepsis. So most antibacterial agents are considered compatible with lactation and not an indication to pump and jump. In general, it's reasonable to, monitor the infant for any GI side effects like diarrhea, potentially look at blood and stools, diaper rash, thrush while they're lactating parents on an antibiotic. Penicillins and cephalosporins are considered safe during lactation. There are tons of evidence on those medications. Bactrim would be considered an L3, but still not an absolute indication to pump and dump. Shared decision-making, higher risk in premature infants, jaundice infants, very ill infants, but again, shared decision-making. Fluoroquinolones like Cipro, Levaquin, again, L3, no absolute indication to pump and dump. Got a call from our ED, a 4-month postpartum female with erythema migrans. We're at Big Lyme around this area. We see quite a bit of that. So that's your bullseye rash with Lyme disease, and that's typically treated with doxycycline. So they had concerns about that. Tetracyclines are an L3, but the main thing is you limit our use to periods less than a periods of three weeks, but it's the same risk of if the infants receive the medication themselves. You worry about dental staining and bone deposition with that. Other antibiotics like macrolides, L2, Flagyl, L2, macrobid, L2. So again, no indication to pump and dump. The next class of drugs, which we're only going to look at really 2 classes, but I say these are the ones I get the most, I hear the most misinformation, and I get the most question from prescribers are antibiotics and psych. So I'm not going to go through each of those, but as you can see, look at all of your options for your L2, lots of information on all these medications, but a lot of these are your first line treatments for things like in postpartum depression, postpartum anxiety. So many options. L3, again, shared decision-making, not an absolute indication to pump and dump. You have a little bit less. L4, as you can see, there's only 3 options, and then there's only 1 absolute contraindication, and this is this doxepin with that. So another one, and again, this is, you can find this on LactMed. There's some great information that can come out at the bottom from different healthcare organizations that have looked at these all together. One that I hear so much misinformation is the treatment of ADHD. So when you look at your stimulant categories of medications, you have your amphetamines and your methylphenidates. Your amphetamines are like your Adderall and your Vyvanse. Those are L3 medications. There's minimal milk transfers. There's no adverse events have been described of infants of moms taking these medications. Large doses of amphetamines may negatively impact milk production by means of prolactin. And of course, as we all know, breastfeeding is discouraged if anyone is abusing amphetamines. When you look at your methylphenidate class, like Ritalin and Concerta, those are L2. The evidence has shown that our milk levels are low and infant levels are undetectable with that. No absolute indication to pump and dump. And then the ones that I see prescribed the most, because prescribers often think that it is safer, is Strattera. There is no published experience with Strattera. Reports from the manufacturer have 2 babies with no adverse events. So limited data, but a lot more information on your other choices for ADHD. So that was a lot. We went through that. I know I only have a couple minutes left, but I really want to quickly go through these other barriers so we can have room for questions. So we went through that first barrier of barriers related to health services. So next we have employment and childcare. Here's me and my girl Spectra with my first baby with that. So how can we, as people who are passionate about breastfeeding and people who want to improve our breastfeeding rates in West Virginia, how can we address this barrier? So first off, make sure our patients know their rights in regards to pumping at work. So according to the breastfeeding report card, 51% of employers have lactation support programs. In December 2022, the Pump Act became law under the Fair Labor Standards Act, and I included that below. Another area is we need to make sure our patients tell their childcare providers or daycare what is the appropriate amount of milk. How many times have we seen women's breastfeeding journeys come to a halt whenever the daycare is saying, send more milk, send more milk. So give them the evidence, send a letter with the evidence showing infants need 1.2.5 ounces per hour away from baby. I work 24-hour shifts, so we would leave 24 to at most 30 ounces for the baby. Talk to your family so that they can talk to their childcare providers about paced feeding. All of these things about normal feeding volumes. Like I said, this is when I see so many women's breastfeeding journeys stop or completely take a turn. So before women leave the hospital and I know they're going to go back to work in a very quick amount of time, I address and anticipate struggles. Some phrases you will hear me say if you're in a room with me is I say, fed is first, your best is best. Whatever you can do, whether that's 50%, 100%, whatever you can do based off the barriers you have in place is the best. And then every drop is a gift and say breastfeeding doesn't have to be all or nothing. I have so many moms that come in and say, I have talked to my boss, I've given them a letter, I'm only able to pump once a day and I'm only giving my baby one bottle. Is that even enough? Is that even worth it? Breastfeeding doesn't have to be all or nothing. So, sometimes we have to reevaluate our goals and consider things like even inclusive feeding. If mom's goal is I want to breastfeed as long as I can, which, that is one of our 2030 goals, is increase our 12-month any breastfeeding rates. Next barrier is lack of knowledge. This is huge in our population. So we really want to empower moms with evidence-based information at every opportunity. I acknowledge that a lot of the misinformation is coming from our colleagues. It is coming from my colleagues in inpatient, outpatient medicine. They're telling moms to supplement when maybe they shouldn't. They're kind of increasing fear in some areas. But if we can empower families with this information and I really try to talk about what is a normal stomach size, what is a normal diaper output, kind of example, you need to have at least one wet diaper for each day of life, that first week of life. What's an acceptable amount of weight loss? Normalized weight loss. Is a rule of thumb, less than 10% is okay, and you got 2 weeks to get back to birth weight. So I really want to make sure people who are taking care of infants are using our NEWT, or the newborn weight tool. It's a fairly new application that was developed that helps look at weight loss in exclusively breastfed infants. Before, they were all kind of lumped together. So it takes into consideration a lot of different variables. So it's a great tool. We also need to, at every opportunity, normalize what is a normal feeding interval, like cluster feeding, because we don't know. We may see them in our office or in our church or in our baseball game Tuesday. Tell them it's okay, your baby's waking up, because they could be met with misinformation the following day at their pediatrician's office. So as much as you can, give that information. Poor family and social support and social norms is the next barrier. This picture of my husband demonstrating perfect pace feeding technique. I was quite the milk hoard. And he supported that, and I'm grateful for that. And I know a lot of people didn't have that experience with that, but I love this statistic. I think it really highlights how those of us who work with women who are breastfeeding or have a relationship in the community with women who are breastfeeding. A 2017 study in the Journal of Human Lactation suggests that a person's confidence in their breastfeeding success can have a marked impact on their actual success, and that the right interventions can significantly increase that all-important sense of self. This statistic just breaks my heart when you look at it from the 2022 breastfeeding report card, but it's something here in West Virginia we know the realities of. They looked at infants eligible for and receiving WIC are unfortunately less likely to ever be breastfed compared to infants eligible but not receiving, or infants ineligible for WIC. We can't change what what a person goes home to. We can't change that mother's not supportive or father's not supportive, but we can at every opportunity normalize fussing, cluster feeding, frequent nighttime awakenings. Lactation problems. So many of you are experts in this. Here's me. Immediately after delivery, and I was grateful and enough and privileged enough to have a lactation expert with me to be able to provide that hands-on care right there. And I know a lot of women don't have that experience. So it's important for us to know that sometimes problems happen, even with the best education and the best support. Problems happen. Delayed onset of lactation occurs in 22% of women, and rates jump to upwards of 44%. If you are meeting women before they deliver at lactation visits or breastfeeding classes, really try and lay that foundation of what to expect. You're not going to have gobs of milk because lots of times, especially if you look at our data in West Virginia, if their mom didn't breastfeed or their sister didn't breastfeed or they didn't have anybody in their immediate circle who didn't breastfeed, these women might not know. So it's better to overshare and over give information as opposed to kind of wait for any issues to happen. And then the last barrier is embarrassment. So this is me nursing my baby and on a ride at Disney World, and my mother looking on a little bit judgingly. But when you got to feed the baby, you got to feed the baby. According to a CDC survey, 69% of respondents believe women should have the right to breastfeed in public spaces. It should be 100%, but 69% is what people believe. And despite our efforts with normalizing things in the media, it still remains a formidable barrier to breastfeeding. And when you look at our data in West Virginia, if you're out at a ball game, which I spend a lot of time on a ball field, if I don't see other women breastfeeding, I might feel uncomfortable. So I'm going to, opt for a bottle instead. And I hate pumping. So things like that. So remember that's still a pretty big barrier, and not all women are as comfortable as others. So, we quickly went through all those barriers, and I'm sure you all can think about either personal experiences or patient experiences, and you can probably see it starts to kind of make light into why kind of West Virginia's data is what it is in a lot of ways. You think about what barriers are in place for a lot of our women, and what things that they have no control of. So it's pretty eye-opening when you think about all those things. So again, looking at those Healthy People 2030 goals of any breastfeeding at 12 months, the goal of 54%. And to me, this is the goal that's most important to me in of one with the relationship with my patients, knowing the population I serve here in the Middle Ohio Valley. Where right now we're at 19% in West Virginia, and then exclusive breastfeeding at 6 months, our goal of 42%, we're at 14%. So hope this doesn't get me kicked out of saying this, but I love this infographic. Breast is not best, fed is not best. Best is being informed about normal newborn feeding behavior, because people don't know. Best is knowing any red flags, when to ask for help. Best is having a support system, including the medical support system, to help you make informed decisions and to encourage you, advocate for you in your parenting and feeding journey. So I want to end with this, this page and kind of go through. So at any opportunity, whether you're in work, out of work, advocate for breastfeeding mothers and dispel misinformation. Whenever you hear it, you may hear it from other physicians, you may hear it from other moms. Dispel misinformation whenever you hear it. If you're a prescriber, engage in shared decision making whenever you're prescribing medications. We all know refer early and often to your lactation clinic. Consider taking those infographics that you can get from the Anesthesia or American College of Radiology or ABM protocols, and incorporating them into your office, into handouts, into your AVS materials, into your consent forms, into pictures in your offices. And definitely have it at your workstation so that you feel confident knowing this information. With that, don't say pump and dump without the evidence, and then acknowledge the barriers to breastfeeding success that are present, and try and individualize feeding goals. So I'm not showing this picture to brag, but to really highlight how grateful I am. This is my first delivery. I had a routine vaginal delivery, no birth trauma, healthy baby, had a lactation consultant immediately at my bedside. I had a mom who also breastfed me, and a husband who were both in awe. There was no, oh, let me hold the baby. There was no, this is completely in all. A lot of our patients don't have this support in their, initial golden hour, let alone when they go home with that. So, and since, breastfeeding success is complex and every person's success looks different and is determined by so many different factors. And until we can support all of our families in West Virginia across all socioeconomic statuses, across all communities, we got to meet parents in the middle with all their barriers, and support their feeding journeys and advocate for them in any ways that we can, in whatever ways work best for them. Thank you. Sorry.
Thank you so much for sharing all of that wonderful information with everyone. Do we have any questions that anybody would like to ask right now?
Thank you so much, Dr. Beckett. That was great.
Wonderful.
Yeah.
Thank you so much. I'm very happy to be here kicking off this month.
We have two questions. For the first one, it says, can you speak more on the pump and dump when it comes to alcohol?
Yes, I love to talk about this. It's a great question, and my answer is gonna kind of blow a lot of people's mind with that. So I start out by saying, when you are pregnant, your blood alcohol content is your baby's alcohol content. You share the same blood system. When you deliver, your blood alcohol content becomes the milk alcohol content. I sometimes have a slide unless I just want to have that includes all of the math in there, that shows. So the risk itself is not from, the baby drinking milk with the alcohol content in it. The risk, because if you look at the alcohol content in orange juice, which you can measure the alcohol content in orange juice, it's comparable to what your blood alcohol content is if you're above the legal limit to even drive. So the risk is from you are so inebriated that unfortunately you like fall asleep on your baby. You engage in safe sleep practices, that engage in unsafe sleep practices that might put your baby at risk. But I'll definitely send that out to Molly and Kelly if anyone has that. But it goes through the exact math, and it, when you companies will sell those test strips where you can save that bunch of baloney, because if you test orange juice, it's going to be positive too.
All right, and thank you, Molly, for answering the other question in the chat. I appreciate that. All right, let's see. That is very interesting about the alcohol content, and I'm definitely going to reference to a friend about that.
Mm-hmm. It's people get surprised about that, but they get confused with the blood alcohol content with milk alcohol content and with all that. But
all right, I'm going to go ahead